morning, sir. I welcome on behalf of myself, Dr. P.C. Dwivedi, Dr. Pramod Kumar Pandey, Dr. Shobhi Pandey, and Shubhangi Bhave. We welcome all the participants on this pediatric session. First, we invite for the keynote address Om Prakash Award, Retropupillary iris claw lenses versus scleral fixated lenses in children with large subluxation. Dr. Tanvi Goenikar.
I think Dr. Valimbe is also here. Could I please invite him out here? Co-chairman.
A very good day to everyone. My name is Dr. Tanvi, and the topic of my presentation is retropupillary iris claw lenses versus scleral fixated lenses using Gore-Tex in children with large lens subluxation. So the management of subluxated lenses varies from optical correction in low grades of subluxation to the removal of the lens and intraocular implantation in higher grades. The IOLs that we implant can either be anterior chamber IOLs, iris claw IOLs, or scleral fixated IOLs, which could either be sutured or sutureless. The sutures that we use can either be 10-0-proline, 9-0-proline, or Gore-Tex. At present, there is paucity of literature which documents the safety of Gore-Tex in pediatric eyes. Also, there is no consensus on which of these techniques is the best for early visual rehabilitation in children. So we undertook this study to compare the functional outcome of retropupillary IOLs and sutured SF IOLs in children with subluxated lenses and to compare the IOL tilt in the two groups. So this study was conducted in 60 eyes over a duration of 1.5 years. The patients were randomly divided into two groups. Group A underwent retropupillary implantation and Group B underwent SF IOL implantation. The primary outcome that we measured was the best corrected visual acuity in logMAR, and the secondary outcome that we measured were the assessment of the IOL tilt, mean change in astigmatism, and the mean operating time. We included patients in the age group of 6 to 18 years with ectopia lentis of more than 7 clock hours and excluded patients with any gross anterior or posterior segment pathology or trauma. So the surgical technique in Group A involved marking of the horizontal meridian followed by a pars plana lensectomy and vitrectomy. This was the iris claw IOL that we used, and the arrow shows the claw mechanism into which the iris tissue was enclaved. After the creation of a superior clear corneal incision, the retropupillary IOL was inserted into the anterior chamber along its shortest diameter. It was held with a lens holding forceps and slipped posterior to the iris. It was then enclaved into the mid-peripheral portion of the iris. We can see the result at the end of the surgery, showing pupil ovalization and a patent iridectomy. The surgical technique in Group B involved marking of the horizontal meridian, followed by the creation of 4 pars plana ports, 2 on either side. These ports were created 5 mm apart and 3 mm from the limbus. This was the SF IOL that we used, showing 4 eyelets. So the Gore-Tex suture was cut into half, and each half was threaded through the adjacent eyelets of the SF IOL. After the insertion of the IOL into the anterior chamber, each of these ends were then externalized through the respective sclerotomies. And this was the result at the end of the surgery. So we observed at the end of 1.5 years, the mean BCVA in Group B was better as compared to Group A. However, it was not a statistically significant difference. We measured the IOL tilt by a method described by Loya et al., in which in the UBM, we measured the distance from the iris pigment epithelium to the anterior surface of the IOL, superiorly and inferiorly for the vertical meridian, and nasally and temporally for the horizontal meridian. If we found the difference between the two to be more than 100 microns, it was considered to be a significant tilt for that particular meridian. So we noted that group B had a higher number of significant tilts as compared to group A, but that was not a statistically significant difference. The change in the astigmatism from the preoperative to the postoperative values in each of the individual groups was statistically significant because of the elimination of the lenticular astigmatism. However, at the end of 1.5 years, both the groups were comparable. And there was a statistically significant difference between the two groups in terms of the mean operating time, with group B having a mean operating time of 90 minutes and group A having an operating time of 40 minutes. So this was a patient of clear lens subluxation who underwent retropupillary implantation. As we can see here, these are the enclavation sites of the retropupillary IOL, and the IOL appears to be well centered clinically as well as on UBM. This was a patient of cataractous subluxated lens who underwent SF-IOL implantation. Here the IOL appears to be well centered clinically as well as on UBM. So if we compare and contrast retropupillary IOLs and SF-IOLs, retropupillary IOLs are associated with complications like spontaneous disenclavation, pupil ovalization, which is not vision threatening, and in the long term pigment dispersion and secondary glaucoma. On the other hand, SF-IOLs are associated with increased manipulation at the vitreous base, therefore complications like retinal detachment, suprachoroidal hemorrhage. Also, they are associated with suture-related complications like suture breakage, erosion, degradation, leading to long-term IOL dislocations. If we compare the advantages, retropupillary IOLs are technically simpler with lesser complications, and therefore they have an early visual recovery. SF-IOLs, on the other hand, are a time-tested method, and they're not dependent on the integrity of the iris tissue. Therefore, they can be safely implanted in conditions like traumatic mydriasis and aniridia. So I'd like to conclude that both the techniques provide good visual rehabilitation in children with large lens subluxations. However, retropupillary being technically simpler, we recommend it in subjects with high risk of retinal detachment like Marfan syndrome, myopia, and peripheral retinal degenerations. Thank you.
And I think there will be no questions on your keynote address. So with that, thank you so much. Very nice study. And then with that, we come to the next presentation. That is
the next paper is Wolfram Language Artificial Intelligence versus Conventional Artificial Intelligence in Pediatric Eye Diseases by Dr. Sunil Morekar.
Can I start? Can I start?
Please.
Hi. Thank you very much. I'm Dr. Sunil Morekar. I'm talking about the Wolfram language. There's no conflict of interest, but I have to tell you that I've done Wolfram language and I help with statistics and research in Wolfram language. The purpose of the study was to study the conventional AI tools in pediatric ophthalmology versus Wolfram language analysis for predicting the outcome in terms of clinical results and the money spent. Globally, we know that roughly around $1,110 per capita is something which amounts to 9.8% is spent on health. In Asia, it's more, and it pushes many people into poverty. 10 million children are affected by rare diseases and with a genetic etiology, and we do not know which case to operate and which case to not operate, where to expect a result. So we use AI. So what is AI for people in a hurry? You take an image, you process the image, put it into computer science, machine learning. The machine tells you deep learning, which tells you a CNN, a neural network, computer vision, and gives you object recognition. And with that, you can find out whether that case is going to succeed or not based on what other people in the past have done. So what is known? Genetic testing has been used. So AI can be applied on the phenotype. So you can look at the phenotype, how the person looks, and do the genotype determination without actually doing a genetic testing, and figure out what complications are expected. What is also known is that the TRACK AI project has been used extensively so far. It has also been used in ROP, and Brown et al. Have developed a software. And these are the various papers on ROP, the retinopathy of prematurity. What is also known that it has been used in pediatric cataract to figure out whether the patient is going to have a high IOP or a PCO severe, and also been used in myopia. But what is unknown is whether it actually has an economic impact and a real world grassroots impact. Audits are missing in literature. Sensitivity, specificity in other eye disorders other than what I have said, and newer languages like Wolfram and its economic impact is unknown. Wolfram is a further refinement made to improve prediction of success and guide treatment. You use the human neuronal network, and between Watson, IBM Watson, the AI, normal AI, and the Wolfram, there are more computational algorithms and real-time data can be input. And you get an extended report as well as a definite answer, not just ranked answer with probabilities. The cloud, like you use a Python, the Wolfram cloud is much more extensive and better. And so the methods we used as study design was real world data. So real world data is very much missing. So we did a clinical audit and economic audit comparison and sensitivity specificity testing. The inclusion criteria was all pediatric cases in the last 1 year. So 1,923 new pediatric cases were analyzed qualitatively using 2 different AI methods. And we compared this with audits over the last 10 years. So we had our own data, conventional data to compare with in previous years. And we had done audits of audits. We use the same standard method as used by Shiraroko. So consenting blood collection, you look at the clinical data, then you look at the research data in terms of genomics and go back to the clinical data and find out whether that correlates with a phenotype. The same electronic data capture and electronic health record, and then you put it into the database. And on the basis of the database, you find out associated diseases, also look at variant analysis and look at this workflow and come back to feeding this. So that's the advantage with Wolfram, you can feed the data back into the system. So the phenotype analysis and the genotype analysis were done. We phenotype participants using automated and manual process drawing from the EHR and used available AI datasets for rare diseases to predict the genotype from the phenotype, and compare that with real genotype data. So these are the available AI and machine learning data sets in literature. So you can pick up from any of them. We in fact did most of them and incorporated many of them. And cases were selected on the basis of classic algorithm and then analyzed for success to test the algorithm. So cases were compared which were done in spite of the algorithm saying that it is going to fail, and with those who refuse surgery when the algorithm suggests a success, and 2x2 table. We used a model to do the hybrid decision tree analysis. These are the support systems which are available, decision support system. We found out that genetic conditions are very easy to identify. Ancestry and consanguinity is a very important factor. So there are some of these results. The hereditary blepharophimosis, you don't know whether it is type 1 or type 2, or OHDO blepharophimosis, whether to do chromosomal analysis can be done. But Wolfram image analysis detects at 98% and 93% specificity with years, microcephaly, and all physical features. The algorithm in its conventional form had a sensitivity of 83% and specificity of 89. In Wolfram form, it increased to 87 and 94. Combined, overall, it had an accuracy of 96%. The overall cost per patient on an average reduced by 15%. And when Wolfram was used, it was much more. Comparing Wolfram to conventional in the artificial intelligence, you can see down below in red is our study. All the others had 89, 93 and all. We had 98 and 95% with high IOP predictions and severe PCO predictions based on the configuration of the lens. Both screening models under societal and health system gained a total of 16.11 QALYs. The telemedicine model had significant lower cost. Under this model, the total savings per person was 79,243 per person, and 43 for the societal and health systems. Some of these cases, cryptophthalmus, these are the results. So would you offer FREM2 gene is something that you would like to find out, but would you offer in particular cases? You look at the phenotype, put it into the system, and you'll tell you, no, you don't do that in the right side, you do it in the left side. Corneal dermoids, if you see a PITX2 gene mutation with a ring-like dermoid, you know that this PITX will be associated with a pituitary abnormality. Clefting syndromes, these are situations where you would not do a surgery in this particular patient, whereas other cases you would see that this is a clefting syndrome with a cleft lacrimal sac, cleft canaliculi, and nose and lip and palate. But the surgery was success because we got to know about that, and also in the sibling. The associations are with these conditions, EEC syndromes, clefting, R298Q can have a right ventricular cardiomyopathy, so you have to be careful. You would like to treat the patient, but you don't want to kill the patient. Hereditary dacryocystitis is something that we used, osteopoikilosis, LMD, and clawfoot, thyroid, squint, complicated squints, and comparison, this was better. NIRD, it was better. Prader-Willi, optic nerve, neurofibromas, and syndromic ptosis. Sedation and anesthesia were considerations, and we discussed that only 5% had treatment so far. We now got treatment in 23%. Application, it gives you cost-benefit analysis, and conclusions, it is superior to conventional AI. Thank you.
Yeah, Dr. Morekar, actually your topic was bit difficult Greek and Latin to us to
So
understand. But
I'm sorry, I can
uh,
explain it in a couple of words
yes.
in case you ask me something.
Yes.
Because I've been working
So
on
would
it
you
for
tell how it is beneficial?
So the major advantage is that when I started off with genetic testing and precision medicine 10 years back, I had to send patients for a genetic analysis, genome analysis, which used to cost 60,000. They used to give us one disease. So for Prader-Willi or something, they'll give us 60,000 for one disease. Today it is available for 9,000 for 12 diseases. But still 9,000 to send a patient to a genetic analysis to figure out what are the various conditions in him. Versus that, if I am able to take a picture, so you take a picture of my face and looking at my face, look at my nose, look at my ears, looking at how my ears look, you can put it into a database, which is an available database internationally for rare diseases. So these databases tell you that this is the phenotype, which is something that looks like an RHD3 or a PITX. So this patient will have a pituitary. So I will not spend money on MRI and all. In all patients, I will do it for this particular patient in which I expect the pituitary to be there. I will not operate on a patient where I know that there is a sedation risk and the patient will die. So what we calculated is that per patient, what would we have spent in terms of getting the patient admitted and then redoing the surgery, So there was a aniridia patient in which we redid the surgery 3 times, and then this patient has an anterior segment fibrosis syndrome. All we needed to know that there was a WAG gene positive. She looked obese, everything was fine. So now I know that this patient should not have been touched, it will get an anterior segment fibrosis syndrome. Another patient which we have done where we know that it is not a WAG positive, so we know that this is the patient in which you should do it. So which patient should we do, which patient should not do? Cataract, which patient will get a very high IOP, which patient will get a PCO, severe PCO in spite of what we do. So should I do a primary PCC? So all of this is something that this thing tells us. We've saved roughly around 1 crore rupees in 1 year in one center.
I think
So
genotype and phenotype don't always match, and I think
They don't always match.
experience, I think that is more important, and each patient is different.
Excellent,
You can't
excellent.
just
See, because all of
have
you,
a very
all your,
uniform approach
so
to
your
everyone.
experience plus his experience plus experience all combined together, you submit to AI, and AI has the experience of 2,000 doctors. So that AI now tells us, okay, your 200 cases, his 200 cases, and then gives us
It can help, you are right, but I think ultimately it depends upon your experience and your expertise in operating these patients. So it can help. That's as adjunct. I think it is
tried
a
that.
good
So I
idea.
compared this with my experience. I'm operating for 25 years.
Yeah.
Each time I say कि ये तो fail होने वाला है, AI says कि pass होने वाला है, माने ये success होने वाला है. I am proved wrong. The AI is proved right. Some people I have said don't do it, मत करो ये सब fail हो जाएगा. Somebody else does it and it becomes better. Here I say this is going to work. 25 years I'm working with this thing. So I tried to convince even the ICO with. I'm a member of the health committee there.
Yeah.
So I tried convincing people that you put AI and you will realize that once you start using AI, our experience 80% it is better. But
Yes, it can
AI,
help. I agree with you.
96%.
But I think basic thing is that how much we understand ourselves and experience and our expertise in operating these
In
cases.
case we employ a computer analyst, so most of my work is done by the computer analyst. He
Yeah.
says, "Sir, machine बोल रहे मत करो."
Yeah.
बोले मेरा experience बोलता है करो.
And
It
rare
fits.
diseases have lot of phenotypic variability, that's another
Absolutely,
problem.
absolutely.
And genotypes also can
Dr.
be
Mai?
quite variable at times.
Thank you,
you.
Dr. Morekar.
इतने सारे papers अपने को खत्म करने हैं ना. हाँ, बुला लियो. Dr. Rishi is speaking on comparative analysis of refractive changes during pandemic in children. Seconds. Ready राहिला तर better होईल.
Good afternoon, everyone. Thank you, Scientific Committee, for an opportunity to share my work on comparative analysis of refractive changes in pandemic during pandemic in children. No financial interest in a few products which I will be showing. As everybody is aware, in March 2020, a national lockdown was declared, once in a lifetime event for all of us, which caused restriction of outdoor activities and more online screen use in children. Even studies prior to the pandemic have found that increased use of online activities leads to myopia progression, as everybody is aware of. But during the lockdown, even at my home also, I saw my children come almost exposed to the screen all the time. There was a study done by a multi-center study. They found that intensive use of digital and virtual learning due to school closure is likely to increase the myopia significantly during the pandemic. So I decided to study my own patients. We analyzed the changes in the refractive errors in children during the pandemic, and we compared it with the pre-pandemic period to find out whether the rate of change was significant or not. So it was partly prospective and partly retrospective study. Actually, we started this in August 2020. So the children which were analyzed previous to that were retrospectively analyzed, and we concluded the study in June 2021. So the first visit was, we included children which had first visit between April 2017 to October 2019, second visit between Jan to March 2020, and from August onwards, it was the third visit. We included children between 5 to 17 years of age during the first visit, and children with myopia or hyperopia more than 0.5 diopters with or without astigmatism. We excluded children with history of prematurity, ophthalmic surgery, squint, and any other ophthalmic condition apart from refractive errors, and also seizure disorders, because as a rule, if there is no neurological problem, we dilated the patient with cyclopentolate and tropicamide, and then we do a dilated diffraction for all children even during the visit, and the difference between two successive visits was noted, and it was counted as a refractive change. The pre-pandemic period was between the first and second visit, and pandemic period was during the second and third visit. So we analyzed the mean refractive change in both the periods, and using a mean deviation as well as standard deviation and 95% confidence interval, we analyzed the refractive change with the follow-up of the patient in months, and we measured the refractive change in both the periods for all the patients, and we divided them into different groups, age groups like 5 to 10, 11 to 15, and more than 15, males to females, and also we analyzed a few patients who were already on diluted atropine right from their first visit. So the study period, as I already mentioned, the number of patients were 90, 45 males, 45 females, 61 were myopes, 29 were hyperopes. Only 10 patients were on diluted atropine, which we analyzed later on. The mean age of presentation was 10.07 years, more for boys, slightly more for boys than girls. The mean follow-up was 26.27 months. In the pandemic period, pre-pandemic period, the mean follow-up was more than that in the pandemic period. And we correlated the refractive change with the follow-up in months using a Pearson's coefficient, and we found that in the pandemic period, the Pearson's coefficient was less compared to the pre-pandemic period. Also, we found that in spite of the lesser duration of follow-up, the refractive change was more in the pandemic period compared to pre-pandemic, though this data was not statistically significant. We considered statistically significant using paired t-test p less than 0.5. So refractive change in males and females were compared in both the periods, and we found that it was more in the pandemic period than in the pre-pandemic, and data was significant. Also in males, the refractive change was more compared to what we got in females. In age group 5 to 10 years and 11 to 15 years, we compared them in both the age groups, and we found that the refractive change in the 11 to 15 years was more than the previous 5 to 10 years age group. Perhaps due to the reduced follow-up period for more than 15 years, we found the data that the pandemic period, the refractive change was less compared to the pre-pandemic period. Comparing the myopes and hyperopes, we found that the refractive change was more in myopes compared to hyperopes, but in both the cases it was more in the pandemic compared to pre-pandemic period. Also in diluted atropine, though the data was not statistically significant, perhaps the number was less. In the pandemic period, the refractive change is more compared to pre-pandemic period, even when the patient is already on diluted atropine. The merits of the studies are that it is the first Indian study to compare the refractive change in the pandemic and pre-pandemic period. We used an office-based examination using dilated refraction, so the chances of getting accurate reading is much more compared to Wong et al., where we used a handheld photo screener without dilation. So, and also we analyzed in different genders as well as age groups. Our study, Y et al., they have used axial length also as a measurement and visual acuity. According to us, the visual acuity measurement may not help much because with the change in refractive error, it will be still normal. But the axial length measurement we had not done for the cases which had appeared previously. Our study was different from Verkicella et al. From LVP, where they found that the myopic progression in 6 to 10 and 11 to 15 is comparable. Our studies in compared to North India myopia study, they have found the refractive change in more in girls than in boys. Ours, it was the other way around. Our study results were comparable with Sherwin et al., where they have found myopia progression more in 11 to 15 years, and with Y et al., where they have found it more in myopes compared to hyperopes, perhaps because the baseline axial length is more. So our study definitely shows that the results will help in further planning of myopia management, and also there is a need for a larger prospective study for myopia progression in the post-COVID era, perhaps which we are. So to conclude, pandemic-induced home confinement increases the myopic shift in children, and myopic shift is more in boys than girls, more in the age group 11 to 15 years, and more in myopes than hyperopes. Thank you.
Thank you, Dr. Rishikesh. Very nice presentation. Only thing I wanted to say that there is emetropization also in earlier age group. If you look at children who are younger, say till 6 years also or 8 years, and myopes are likely to progress, say from 6 to 12 and then beyond at around this thing till 22 years in in that period. So it becomes quite diverse. Your groups become quite diverse.
Yes,
I mean,
there are
had
many
it been
other
only
factors,
myopia, probably, had you taken only myopes, or maybe that would have been more, do you agree with me, would have been more specific and...
Yes, sir. Actually, we have done another study only for myopes, but we were interested in what happens to the hyperopes as well, because there is significant people, children who have hyperopia. Also, we did not include children less than 5 years, because many of them actually didn't turn up during the second wave for follow-up. So even the follow-up was a bit haphazard, actually, difficult during that period.
So, that's
Just one, how did you calculate the rate of increase in the refractive error pre and post pandemic?
We compared the refractive change, we noted the refractive change in 3 visits. One is the first visit and second visit. That was the pre-pandemic period, and the pandemic period was between the second and third visit. And these two we compared, what was the change in these two.
you didn't take axial length, you did not?
No, sir, because a part of the study was retrospective, and we had not measured the axial length in that for those children. So we did not include that in our study, actually. There was no nothing to compare it
Time period was
with.
different though, no? Time period for
Yes.
pre-pandemic was more as compared to time period for
During the pandemic,
during
yes.
pandemic.
It was lesser in pre-pandemic. Thank you.
Thank you. Thank you.
Yes.
Dr. Amit Mohan, is he there? Yeah. Please come. And he'll be talking about safety and feasibility of posterior optic buttonholing in complicated pediatric cataract surgery.
Good morning, everyone. I am going to present safety and feasibility of posterior optic buttonholing in complicated pediatric cataract surgery. There is no financial disclosure. As we all know that primary posterior capsular access with anterior vitrectomy is now routinely performed in young children to prevent PCO. This PPC can also be used to perform posterior optic buttonholing, which theoretically reduces chances of pupillary capture and other complications. POBH in pediatric cataract surgery is basically described for prevention of PCO. The aim of the current study is to find the newer indication of POBH in pediatric cataract surgery other than for prevention of PCO, and to evaluate the intra and post-operative complication of IOL implantation with POBH in these children. This is a retrospective, non-comparative clinical interventional study done at Sadhguru Neta Chikitsalaya, Chitrakoot in 2019. Children operated for cataract with definitive indication of POBH other than PCO formation were included in the study. Pre-operative and intraoperative evaluation were done, and indication of POBH in that particular case were noted. This is our surgical technique of POBH. This is a case of extended anterior axis in which we have implanted 3-piece intraocular lens inside the bag. Then the primary posterior capsular access with anterior vitrectomy was done with vitrector, 23 gauge vitrector, and the optic of the IOL was pushed behind the posterior capsular access margin to do the POBH. Spindle cell shaped configuration of the posterior access margin confirmed the POBH. Patients were followed up at day 1, 1 month and 6 months, and each follow-up visit, ocular inflammation, IOL position, IOL centration, and posterior capsular opacification were noted. These are our definition. The heightened post-operative inflammation was considered if anterior chamber cells are flare more than +2, raised IOP if IOP more than 22, decentration or tilt was also noted. Out of 1,470 operated pediatric cataract surgery during study period, total 139 children underwent for POBH. The mean age of children was 7.4 years, 84 were males. There were 76 developmental cataract and 63 traumatic cataract. Mean follow-up period was 1.2 years. Indication of POBH in developmental cataract in our series is anterior capsular axis extensor, large anterior capsular axis, posterior capsular tear, posterior lenticonus, anterior megophthalmos, absorbed cataract, PHPV, complicated uveitic cataract, and membranectomy. Indication of POBH in traumatic cataract in our series is ruptured ALC, large PCR, absorbed cataract, and secondary IOL. These are the post-operative complications of POBH in our series. Anterior chamber inflammation more than +2 was noted in 18 children at day 1. At 6 months, 2 patients has IOP rise, 3 has IOL decentration, 2 has IOL tilt, and 2 had PCO formation. These are the visual acuity categories in last follow-up in our series. Discussion. In congenital or developmental cataract, sometimes there is extension of anterior CCC or large size CCC. In such cases, even if the IOL is implanted in the bag, there are increased chances of migration of IOL from the capsular bag through deficient anterior capsular axis margin, leading to pupillary capture of IOL optic, iritis, postoperative glaucoma, and posterior capsular opacification. Carifi et al. Reported a higher incidence of intraoperative complication in anterior capsular tear. In this study, we noted 26 eyes with anterior capsular axis extension and 6 with large CCC. POBH resulted in less postoperative complication in our series. These are the cases of POBH in extended anterior axis. This is a POBH in Argentinian flag sign, posterior capsular tear. We have also performed POBH in 5 cases of PCR and 4 cases of posterior lenticular. IOL implantation in the bag was difficult in such scenario in fear of IOL drop or decentration, and sulcus implantation without POBH leads to anterior segment complication. So we have implanted 3-piece IOL in sulcus with optic capture of IOL through anterior CCC. This is the POBH in pre-existing PCR. This is the POBH in a case of posterior lenticonus. In 3 cases of anterior megophthalmos, IOL was implanted in the bag with POBH in our study. Capture of IOL optic in posterior capsular opening provide good fixation, centration, and stability of IOL. In absorbed cataract, membranectomy, and secondary IOL, we have also done POBH with little complications. These are POBH in absorbed cataract. This is the POBH in a case of secondary IOL. In 8 uveitic cataract, we have performed in the bag IOL implantation with POBH. With this approach used in our study, none of the patient developed chronic inflammation, and secondary retrolental membrane formation was not noted in any of the patient. This is a case of POBH in a uveitic cataract at 1 year follow-up. In PHPV cases also, we have done the POBH, and none of them developed PCO, while the other study shows that many cases developed secondary membrane. This is the case of POBH in PHPV with ruptured PC. In also traumatic cataract, we have done the POBH with good results. These are the POBH in different cases of traumatic cataract. Our study adds on the current literature as a different and newer indication of POBH in pediatric cataract surgery. Major strength of this study is that it is first of its kind where vitrector axis is used for POBH with good and repeatable results in different indication. Major limitation of our study is it's a retrospective study without any comparative study group of standard surgery. Thank you.
Thank you, Dr. Mahajan, for a wonderful presentation. You have large number of cases too. Did you do an anterior vitrectomy too? Or
yes, sir. Because we have made the PPC with the vitrector, 23 gauge vitrector.
Okay.
But you have not compared visual outcomes, you have not shown us. I mean, were they better than anyway?
Visual category we have categorized.
Yes,
because your cases are very diverse, some traumatic, some developmental, so I think that makes a very variegated cohort. So I think
I have tried to find out the newer indication of POBH because POBH is basically described for the PCO formation, but we have in most of the cases here in which the angle in the sulcus implantation is there, then we have done the POBH, or if there is a deficient anterior rhexis or we are not able to open the rhexis, then we have done the POBH and see the results. Whether any
with the POBH, it is said that it's the advantage is that we don't need a vitrectomy.
Mostly
for the vitreous
mostly for the PCO, it is described that manual and posterior axis should be done and POBH without anterior vitrectomy. But here we have done, because the vitrector we have made the PPC, and so we have done the
Did
minimal.
You find any case of posterior capsular extension?
With the vitrector, in 1 myopic cases, we have found the extension during the POBH.
Okay, very good.
Thank you.
Next.
Dr. Dipanjana Das.
A very good afternoon to all. I am Dr. Deepanjana Das. I will be presenting the topic of preserve the vision in thalassemic children. Thalassemia is a group of inherited disorders due to mutation causing decreased synthesis of alpha and beta globin chain, causing deficiency of hemoglobin and red cell changes. India being the largest amount of thalassemic population in the world, every year 10 to 15,000 babies were born in India. Both the disease process and treatment strategies affect our multiple systems of the body as well as ocular system. The iron chelating agents that are used for treatment chelates multiple micronutrients that are also useful for retinal functioning. The iron overload alters normal tear film production, hence causes ocular surface abnormalities. The other manifestations are lens opacities, retinal pigmentary changes. Our study was a randomized prospective cross-sectional study. 100 children of 6 to 12 years of age who were confirmed the disease by high-performance liquid chromatography were selected. They were undergone a complete ophthalmologic examination including visual acuity, subjective refraction, tonometry, Surmer's test, slit lamp examination, indirect ophthalmoscopy, and the hematological tests were done for hemoglobin and serum ferritin. If we see the results, the maximum number of our patients were in the 6 to 8 years of age group. The patients, 27% of children had serum ferritin level less than 1000 nanogram per ml, and 73% of children had serum ferritin level more than 1000 nanogram per ml, for which they were under chelation therapy. 35 patients of our population had refractive error, 16% of them had myopia, hypermetropia was present in 10% and astigmatism was present in 9%. 14% children had dry eye syndrome, out of which 67 had mild, 11% had moderate and severe at 22% children. If we see the parameters of the dry eye, 2 patients showed Surmer's test value less than 5 and the mean tear film breakup time less than 5 seconds was present in 3 children. 5% patient had presented with lenticular opacity, out of which 2% were visually significant. And the children presented to us conjunctivitis of different etiologies. 3 children had myopic disc, 7 children had macular pigmentation. Tortuous vessels was present in 3 children. The causes of reduced visual acuity were refractive errors, dry eye syndrome, cataract, anterior segment and posterior segment pathologies. 35% children had myopia, out of which myopia had refractive error and out of which myopia was 16%. In a study by H. Samira et al., the prevalence of myopia was 16%, hypermetropia was 19% and emmetropia was 63%. Similar study by Batra et al. Found that significant amount of children had amblyopia. In our study, the 14% children were suffering from dry eye. Garteganis et al. Reported in their study that the iron overload causes goblet cell loss and metaplasia of conjunctival cells in these thalassemic children. 1/3 of the population, cataract was present in 5% of children, out of which 2% was visually significant and they needed intervention. Divan P. et al. Showed higher prevalence of cataract in thalassemic children and this prevalence was associated with higher serum ferritin level. Jethani et al. Found that isolated cataract changes in the lens were the most common anterior segment findings in the untreated thalassemic children. Dahlia SM reported decreased visual acuity in 45% of children. RP pigmentary mottling was present in 25% and 12% had disc hyperemia. Dhara K et al. Reported that ocular toxicity was more in children with higher serum ferritin level. So our results were finally correlated with many previous scientific literatures, and this gives emphasis on the need of ocular examination of these thalassemic children. Though our study was limited due to the 6 children who were excluded from the study, who were the more risk remain unexamined. The 1/3 of the population, our children, were suffering from refractive error. And if this error remain undetected and untreated, the development will be hampered. Ultimately, this will turn into irreversible stage of loss of vision, leading to amblyopia. To prevent this complication, every child needs to be screened and treated accordingly on time, because every vision is priceless. And these are the references I have used. Thank you.
Thank you so much. Did you compare with a normal control group, because children may have same kind of refractive error as all the children in the population? Did you
So
have any control to
because
say that the
it was
incidence
a-
is more in these thalassemia children? Either some complications or problems with thalassemia, ocular findings, if we try to study that, that will be more
Sir, it
relevant.
was a cross-sectional study. That's why I have not compared with another any control group because but we should do.
My point is that same kind of findings you may have found in
Yes,
normal
yes.
children also.
Yes,
That is
obviously.
my main point.
But so my point was that the normal children, mostly our children come to our OPD due to the refractive error, having refractive error reduced visual acuity. But this child remain overburdened with their systemic problems. They visited hospital frequently, but they do not come to ophthalmology OPD. So if they are coming every month for blood transfusion or any causes, they are admitted in pediatric department, but their ophthalmological examination is not done. So we should include in their
And thalassemia is also thalassemia major, minor. I don't know too much about thalassemia, but it's a very complicated and very
Yes.
vast topic. So I think some segregation, maybe those major and minor, all those issues probably need to be studied, and how well they were treated, probably that was also
Yes, sir.
relevant. Probably, and no bleeding issues you found with any child, no hyphema,
No, sir,
retinal
actually we
hemorrhages or any.
excluded the 6 children.
Okay. Thank you.
Thank you.
Dr. Rajvinder.
Dr. Rajvinder will be presenting an interesting case of spontaneous globe rupture, unusual ophthalmic manifestation with dengue hemorrhagic shock syndrome.
Good afternoon, everyone. The topic of my presentation is the spontaneous globe rupture, an unusual complication with the dengue hemorrhagic shock syndrome. Dengue is transmitted by Aedes mosquito. It starts from the asymptomatic febrile illness to fatal hemorrhagic fever. Severe dengue hemorrhagic fever is characterized by the extensive plasma leakage manifested by the fluid extravasation in the lungs and abdomen, involving the multiple organs, leading to respiratory distress and dengue shock syndrome. So the child was 9 years old male, presented to pediatric emergency with high-grade fever, abdominal pain and vomiting for 7 days, altered sensorium 6 hours before presentation, history of 2 random platelet transfusion in few days. And there was normal developmental history. The child was lethargic, not oriented to time, place and person. Vitals were unstable and BP was 80/50 in right arm in spine position. And GC score was eye opening 2, vocal response 2 and motor response 5. Ophthalmic consultation was done in view of the acute right eye swelling. So visual acuity and the digital tension could not be assessed because of the altered state of consciousness. Eyebrows bilaterally symmetrical, visual axis and ocular movements as he was altered state of consciousness. And the acute abaxial proptosis with no variation in posture associated with periorbital edema. Skin was warm and tender to touch. There was no leg ophthalmos, no dilated episcleral vessels. Hemorrhagic chemosis involving the inferior palpebral conjunctiva was present in the right eye, left eye was normal. And the details were not, pupil lens and fundus were not visible because of the full blood, fresh blood hyphema in the right eye. And cornea was with the dull luster. So on the presentation, we can see in the picture diffusely illuminated clinical picture of the right eye. On the first examination showed the anterior displacement of the right globe, hemorrhagic chemosis, dull cornea and mid-dilated pupil with the hazy media. And after 2 hours of first presentation, we can see the blood on the medial side, full chamber hyphema and extensive hemorrhage was noticed near the limbus after the 2 hours of first examination. So contrast enhanced MRI imaging and orbit were done to rule out the intracranial bleed at the globe rupture. And this is the picture showing the proptosis in the right eye, and we can see in the hypertense various echoes in the right eye showing the hemorrhages, retinal hemorrhages, choroidal hemorrhages, and we can see the proptosis in the right eye also. And this MRI shows imaging the right eye with the interior displacement of the globe with the punctured right eyeball as compared to the left eyeball, which looks like well formed, the left eye, but the right eye looks punctured, and the hypertense and the hypoechoic echoes in the right eye. So the multiple hyperintense lesions were present in the bilateral ganglionic and the left subcortical white matter region on T2. Dynamically, the TLC was 18,000 cubic per millimeter, and the platelets were 45,000 after that. And possible mechanism for the globe rupture could be the increase in intraocular pressure, which is evident from the apparent enlargement of the eyeball, as seen in the radiological examination. Increased intraorbital pressure, which results in dilatation of the retrobulbar space, secondary to the retrobulbar and suprachoroidal hemorrhages. In this picture, we can see the break in the continuity of the outer wall of the right eyeball with extrusion of intraocular contents is visible in the sagittal section. So the patient was diagnosed as dengue hemorrhagic shock syndrome and started on supportive therapy with the platelet transfusion. The topical medication in the form of dorzolamide and temolol was started because of his systemic condition. We were not able to do the lateral canthotomy. Intravenous methylprednisolone was given in view of immune-mediated pathology. IV mannitol and other hyperosmotic agents are contraindicated due to deteriorating blood pressures. Canthotomy was deferred because of the to avoid excessive bleeding. The child was conservatively managed with antibiotic eye ointment, pressure bandage, and ultimately the child succumbed to extensive systemic involvement in spite of aggressive management. Dengue fever is self-limiting with less than 1% case fatality. But if not treated adequately and early, the mortality can be as high as 20%. Prognosis in dengue hemorrhagic fever and dengue shock syndrome depends upon the prevention and early recognition and treatment of shock. Although the pathogenic mechanism of ocular complications associated with dengue fever remains unclear, the mechanism is believed to be immune-mediated rather than direct viral infection. So these are the two case reported, which are given in the references. The cases are already been reported in adults. The spontaneous globe rupture, a case series, and the one case report by the Chatraj Jaydev and Nagaraj of the spontaneous globe rupture. But this is the first case reported in a child. Ophthalmologists and a pediatrician should be alert regarding the vision-threatening manifestations related to dengue hemorrhagic shock syndrome. Timely diagnosis and early management can improve the outcome of the disease. This case has been published in the American Journal of Ophthalmology case reports. Thank you.
Yes, thank you. That's a very rare case you've presented. It is very unusual for a normal globe to rupture. In cases of absolute glaucoma, when the sclera is very thickened, we can have, but a normal globe to rupture is very rare.
Yes, ma'am. Normally, we in the OPDs we usually see the subconjunctival hemorrhage in the retinal blades, but such type of a presentation was just alarming to us also, and just presented because this can occur. No, sir, he was not having. Yes, sir.
Yes.
Thank you, sir. Thank you, sir.
Investigations for dengue, they were all in order. I mean, it was.
They were related to dengue.
Coincidental finding. My issue is that was it just coincidental that he had child had dengue, or?
No, he was referred from the periphery related to the treatment also, because he was getting worsened because of the hemorrhagic shock. So he was referred. He already had a random platelet. That may be a risk factor because of counts were low, definitely, sir.
Is Dr. Varuna Abhinetri here? Yeah. She'll be talking about impact of online vision therapy on functional vision of children with multiple disabilities.
Good afternoon, one and all. I'm going to talk on impact of online vision therapy on functional vision of children with multiple disabilities. Financial disclosure. According to Intellectual Disabilities Education Act, multiple disabilities is defined as concomitant impairments, a combination of which causes severe educational problem that they cannot be accommodated in a special education program solely designed for one of the impairments. Impairment of functional vision has impact over motor competencies, cognitive and social aspects of human life, and prevalence of such impairment in children with multiple disabilities is about 10.5%. Continuous rehabilitative support is needed for sustained development and to curb the potential delay in the global development of children with multiple disabilities. But during COVID, only essential services and emergency services were available. The travel restrictions were imposed and rehabilitative services were not part of essential services, because of which the children with multiple disabilities had regression in their sensory and motor skill development, showed increased behavioral problems, and parents had added responsibility of providing rehabilitative support without any professional help. So during the second wave of pandemic, due to increased parental concern, online vision therapy was started. The aim and objectives of the study was to analyze the transition in functional vision, that is grating visual acuity and contrast sensitivity during in-office vision therapy, no therapy period, and online vision therapy, and also to study the adequacy, effectiveness, and impact of online vision therapy as perceived by their parents. This was a retrospective observational study done on 15 children with multiple disabilities at Department of Vision Rehabilitation Center in a tertiary eye care setup based in South India. Children with multiple disabilities who were previously enrolled for in-office vision therapy, who are on regular follow-up and subsequently adopted online vision therapy and completed 25 sessions, that is 6 months of online vision therapy, were included. And those children who were not previously enrolled for in-office vision therapy, who did not complete regular follow-up due to other medical illness, and children who did not complete 6 months of online vision therapy, and those parents who did not show willingness for this online therapy and who had difficulty in accessing the platform, e-platform, were excluded. So methodology included complete comprehensive eye examination by pediatric ophthalmologist, following by functional vision assessment, that is contrast sensitivity by hiding Heidi chart, and grating functional assessment by means of LIA grating paddles. And this was used for baseline vision assessment as well as the post-therapy session. After which the online vision therapy was conducted using Zoom platform, and before any session there was a pre-session where the special educator would contact the child's parents and would brief about the next day's session. The feeding time, the sleeping time of the children will be noted, the availability of the material and support will also be noted. During the session, if the children was verbal, the special educator would communicate with the children directly or otherwise with their mother or with the other parents. Then each therapy session will lasted for about 45 minutes, during which, based on the rehabilitative strategies planned for each and every child, the rehabilitation therapy was given. After the online vision therapy, a person who was not involved in the rehabilitation service was collecting the response of the patient for their satisfaction level, which the questionnaire was administered by an oral interview. So these are the results. This is a table showing the grating visual acuity changes during pandemic. So before the first lockdown, the median visual acuity was about 1.5 cycles per degree, which regressed to 0.9 cycles per degree during the first wave of pandemic, which was statistically significant regression. And when in-office therapy was restarted once the travel restrictions were lifted off, it showed a statistically significant improvement. And then when during the second wave of pandemic, when online vision therapy was given, it showed that the grating visual acuity was maintained, that there was no statistically significant regression. So this is the contrast sensitivity changes. Here, the 12 children were under testable category when before pandemic, and then during pandemic, since there was no intervention, it regressed to about 9 children who were under testable category. 3 children regressed to non-testable category, and then after restrictions were lifted off during in-office vision therapy, 4 children improved and 13 children became testable. And during online vision therapy, that is during the second lockdown, it was maintained. And these 2 children, they continued to be in the non-testable category because of profound PL vision. So any deterioration either in the contrast sensitivity or in the grating visual acuity will be taken as a deterioration in the functional vision. So plotting that in a graph, about 11 children showed worsening of functional vision without any intervention, and during in-office as well as online vision therapy, the children showed either improvement or maintenance of functional vision. So these were the questionnaires which were administered to assess the satisfaction level among the parents. Majority responded in affirmative. And few parents, they had issues of lack of family support. So majority showed regression without any intervention, and this was also supported by T. Battiston et al., who did a similar study to study the satisfaction level among parents and showed high satisfaction level. And these were the advantages and shortcomings. Mainly, the advantages was the safety level, the accessibility, it eliminated the waiting time for the patient, especially for children with seizures, and the shortcomings were this could not be applicable for children with profound PL vision, and this does not match the special bond between the special educator and the children with multiple disabilities. And to conclude, though this is not a replacement, online vision therapy can always be implemented along with in-office vision therapy whenever it's needed, and does not have any compromise on functional vision, and also has high satisfaction level among parents. Thank you.
So it's a good discovery during pandemic, as we have discovered that we can continue our webinars and without any without meeting each other. So
yes,
it's a good fallout of the pandemic.
Yes.
Yes, thank you.
Thank you.
Could Dr. Preeti please come over for a talk on progressive pediatric keratoconus?
Good afternoon, one and all. I'm Dr. Preeti, and I'll be presenting my free paper on outcomes of accelerated collagen cross-linking in progressive pediatric keratoconus. So keratoconus is a degenerative corneal ectatic disorder that causes thinning of the cornea, irregular astigmatism, and visual deterioration. It's most commonly found in the second decade of life. However, pediatric keratoconus is known for its rapid progression, and the risk of pediatric keratoplasty is 7 times higher as compared to the adult population. So collagen cross-linking is the other treatment option available. So the purpose of my study was to determine the safety and efficacy of accelerated CXL in pediatric population. So the study was a prospective interventional study conducted at a tertiary eye care center in South India. The inclusion criteria for a study was patients with age group less than or equal to 18 years. Progressive keratoconus, we documented 6-month progression. So increase in the manifest spherical equivalent of more than 0.5 diopters, increase in the keratometry maximum or K mean value of more than 1 diopter, or 2% or more decrease in the thinness pachymetry, and a follow-up of 1 year was compulsory. However, patients with central or paracentral scarring were excluded. Corneal thickness less than 350 microns were excluded. Active ocular infection or severe inflammation, patients with diabetes, thyroid, or autoimmune disorders were excluded from the study. So all cases underwent a routine ophthalmic examination, specular microscopy, and pentacam analysis, where we took the Ka values, the central corneal thickness, and the thinner corneal thickness. So in our cases, all cases underwent an epithelial of accelerated collagen cross-linking. So cases which had a thickness of more than 450 microns, we used the isotonic riboflavin solution. However, with less than 450 microns, we used the hypotonic riboflavin solution. So there was mechanical debridement of the corneal epithelium. We debribed 8 to 9 mm of the epithelium, instilled riboflavin solution for 20 minutes with intervals of 3 minutes between them. Then after which, we gave the patient an irradiation of UVA. The irradiance was 9 milliwatts per centimeter square for 10 minutes with intermittent instillation of riboflavin. So the follow-up was scheduled on day 1, day 5 for the removal of the bandage contact lens at months 1, 3, 6, and 1 year follow-up. So these were the results. So we had a predominance of left eye, 52% as compared to 48% were right eye, and a male predisposition of 54% as compared to 46% of the female predisposition. Now the age group distribution, the mean age group was 15.59 plus or minus 2.39 years. So the youngest in our study was 9 years of age. So again, the percentage, we mostly used hypotonic solution. We mostly used isotonic solution in 52% and 48% hypotonic. So these were the results. So all these results were tabulated at pre-operatively and 1 month post-operatively. So as you can see, there was an improvement in the uncorrected visual acuity from 0.87 logMAR units to 0.76, and also in the best corrected visual acuity from 0.42 to 0.22. Now all the keratometric values, there was a decrease in the K1, K2 and Kmax. So the K1 from 48 to 48.8, from K2 51 to 51.8, and Kmax from 54.41 to 55.1. However, in 2 cases, the Kmax had worsened by more than 1 diopter, and the best corrected visual acuity of these 2 patients had decreased by more than 1 line, indicating that these cases progressed. So corneal astigmatism also had decreased significantly from pre to post-operatively by almost 0.5 diopters. There was a thinning of the central corneal thickness and the thinnest corneal thickness. The mean endothelial cell count, however, did not change pre and post-operatively, and it was statistically insignificant. Now the complications, we encountered the complication of a persistent corneal haze in 2 patients. So we treated these patients with topical steroids, and over a duration of 4 months, these patients improved and the haze disappeared. However, one eye developed a sterile infiltrate in the paracentral area. The patient was treated with topical steroids and artificial tears, and the patient did well thereafter. So coming to the discussion, pediatric keratoconus is known for its aggressive nature of progression, and CXL has a very important role in the treatment. So early diagnosis, documentation of progression, and prompt treatment will ensure a good visual outcome, and it will avoid the need for pediatric keratoplasty. Now the advantage of epithelial of accelerated CXL when compared to the standard procedure is that you give a higher irradiance in a shorter duration. It reduces the surgical time, especially this is an advantage in a pediatric case, and it has similar efficacy and safety as compared to the standard procedure. Now, in our study, there was a 2-line improvement in the best corrected visual acuity and 1-line improvement in the uncorrected visual acuity as compared to many studies by Shetty et al., Capriosi et al. There was also reduction in the corneal thickness. Now, this is because of the remodeling that happens in the cornea. There were improvement in all keratometry indices. Now, when we want to monitor pediatric cases, we mainly look at Kmax, which is a very valuable parameter to demonstrate progression. The complications of sterile infiltrate and persistent corneal haze that occurred in our study were managed well and did not have any visually impacting complications. So, but the limitation of our study is we had a smaller sample size and a shorter follow-up duration of 1 year. So further follow-up is needed. In this 1 year, we had 2 cases with progression. So further follow-up is needed in evaluating the progression. So in conclusion, pediatric accelerated CXL is effective, efficacious, and safe. The time of intervention, if to wait for progression or to perform prior to progression, remains a questionable factor. However, even after performing CXL, we need to monitor these cases slowly. So this is a case of corneal haze. And this is a pentacam where you can see all the keratometric values have improved pre and post-operatively. These are my references. Thank you.
Thank you for a very nice presentation. Did you have any control group to come, I mean, with older age group, could you, because...
so we are doing a study on the adult population also, but we haven't done a comparison yet with the adult population.
Because if the results are as good in adults, what probably you give the message, we should catch them young. I mean, do it earlier than postpone it.
Yes, sir.
That is,
and here we have taken only progressive cases, but we are currently doing a study in which when we see a stage 2 or a 3 keratoconus, we directly intervene without doing progression. So we are going to compare the results there too, sir.
So it is as good as in adult and older age group.
Yes,
so
sir.
Anyway, the problem is of younger age group.
Yes.
Keratoconus is young age problem. So you have done under 18 and post 18, we need to, I think, compare and see.
Yes.
So in in the study, you had 2 cases who had progression.
Yes, ma'am.
So do you feel that it is because of the accelerated CXL proforma you have used, or it could have happened with the conventional?
Ma'am,
also?
even in the conventional, a study by Alprosi has taken the progression rate to be 16%. So they did a study with the standard CXL for 3-year follow-up. And they had a progression of 16%, another study for 7%. So since mine was a 1-year study, so accelerated or standard, it can still have progression. So it is independent of the type of C3R.
And this needs a longer follow-up, I think.
Yes,
1 year is a very short time.
Yes, so 1 year is a very short
Yeah,
time. Yes.
Thank you.
Could Dr. Sonali Rao come over, please? Impact of screen time on ocular surface in children. Very relevant.
Good afternoon, everyone. I'm going to talk about the impact of screen time on ocular surface in children. We know that the daily media consumption has increased in today's pediatric age group, and the use of smartphones and tablets is a new normal, especially during the pandemic. So increased use often leads to a variety of synopic symptoms. Pediatric population is generally more tolerant to these symptoms, so many of them go undiagnosed. So there is a strong need for a uniform protocol to screen for dry eye irrespective of the symptoms. So what we did in our study is we wanted to evaluate the impact of the electronic media use on the ocular surface health in children. So this was a cross-sectional study with purposive sampling. We included children who attended our OPD between September 2019 to October 2020 between the age group of 5 to 15 years who were using the appropriate spectacle correction. Children with congenital abnormalities of the eye, autoimmune diseases, prior surgery to the eye or trauma or severe allergy were excluded from the study. Appropriate statistical analysis was used. So we included 78 children in the study, and each parent was given a standardized questionnaire to answer, and a detailed slit lamp evaluation was done. Dry eye evaluation including OSDI scoring, Schirmer's test, T-BUT and fluorescent staining was done in all kids. This was a questionnaire that was given to the parent. So we had 78 children analyzed. The mean age group of was 11 years. 42% were females, 57% were males. So 45% of these children used smartphone and television. 19% used all 3 devices. 19% used smartphone only. 12% used smartphone and computer. 5% television. And there was no child that only used computer. So based on the screen time, we divided the group into less than 1 hour of smartphone as a control group and more than 1 hour of smartphone as a study group. In the control group, less than 3 hours of other media was control group 1, more than 3 hours of other media was control group 2. In the study group, less than 3 hours of other media was study group 1, more than 3 hours study group 2, and more than 4 hours of smartphone was study group 3. So based on this, in the control group 1, we had 21 children, control 2, we had 4, study 1, 41, study 2, 6, and study 3, 6 patients. So percentage of those with symptoms increased as the screen time increased. We had 70% who presented with headache, tearing, burning sensation, and headache was a predominant symptom. Coming to the OSDI scoring, the OSDI score was more than 12 in 57.7% of the population. And we see here that as the OSDI score increased when the screen time increased, and the p-value was significant. Coming to the Schirmer's test, the Schirmer's test also decreased as the amount of screen time increased, with a p-value of 0.06 in the right eye and 0.02 in the left eye. None of the subjects had a Schirmer's value of less than 10 seconds, but it showed a decreasing trend as the screen time increased. Coming to the tear breakup time, the tear breakup time also decreased as the screen time increased, and this was statistically significant across the study groups. Next, coming to the positive fluorescent staining test, this was noted in 7.7% of the population. However, this was not significant. So, but fluorescent staining was higher in those with more screen time. So, comparing our study to other studies in the literature, the study done by Zhang et al., he compared adults and he compared smartphone versus OSDI scoring, and he said that smartphone aggravated the OSDI score. Another study by Zhang et al., He evaluated children between the age group of 10 to 12 years, and it was a large sample size. He compared electronic media use with T-butt and fluorescent staining. He also concluded that smartphone is an increased important risk in the dry eye in children. The third study by Katharina et al., she also compared children between the age group of 3 to 10 years, and she compared smartphone versus visual issues, and she concluded that asthenopic symptoms was higher in the video game group. The only study that contradicts her study was by Benjamin et al., but he did the study in adult population. So he compared the commonly used dry eye parameters like us using Schirmer's, T-butt, OSDI, and fluorescent staining, and he did not demonstrate any concordance between any of the signs or symptoms. So our study revealed that a significant portion of the study population had symptoms. The OSDI score showed a significant increase in those with very high smartphone use, and the T-butt showed a decreasing trend as the screen time increased. While the fluorescent stain was not statistically significant, but it was higher in the group with the high media use. So while the results did not indicate a severe disease, but the OSDI and T-butt values showed a significant change as the duration of the screen time increased. In this generation of ever-increasing dependency on electronic media devices, both children and parents need to be aware of the ill effects. So studies like these compare the direct effects of screen time on ocular surface health in children become important. Our study had a smaller sample size and it was a limited duration of only 1 year, so that was the limitation of our study. So there is a need for a more holistic diagnostic policy that can diagnose dry eye before their apparent symptomatic manifestation. Thank you.
Yeah, thank you. Thank you for a nice presentation. And most of the times we see that children do have symptoms, though they may not have signs of dry eye.
Yes.
They definitely come with symptoms which are more with the increasing use of screen time.
You couldn't have found children who were not using these devices to compare, I think.
I don't think
every
there was
child is-
anybody who didn't use device, because all of them were having online school during the time between October and September 2020. So most of them were using smartphones. And we didn't find any children who only use computer, which was surprising. Most of them had smartphone.
No, I'm saying you couldn't find children who were not using
No,
either of
we-
these.
no, we couldn't.
That is the main issue.
That was not there.
That is
Did the screen size affect the surface?
More than the screen size, I would say the distance between the screen and the viewing affects more, because here the children with the smartphone had like more of dryness, decreasing Schirmer's, T-butt, and fluorescent staining. So it's not the size, but it is the distance.
It is blinking, I think. You blink less frequently, and that
Yes,
makes, I
yes.
think, a lot of difference.
Yes.
Tear film issues, I think, arise
Yes.
mainly because from blinking frequency goes down. I think
Yes.
that's the main thing. Thank you so much
Thank
for
you.
very interesting presentation.
Thank you. The last presenter for today, Dr. Debolina, could she come up? Yeah. Role of septicemia and surgery in preterms during NICU stay towards ROP.
Good afternoon, respected judges and everyone. My name is Dr. Debolina. I'm presenting on the role of septicemia and surgery in preterm babies during the NICU stay towards ROP. As we know, ROP is an upcoming vascular proliferative disorder that is an important cause of childhood blindness. We are specifically studying on the role of early neonatal surgeries these babies undergo during their stay in NICU, specifically surgeries like inguinal hernia, necrotizing enterocolitis, and hydrocephalus, because they undergo these surgeries under general anesthesia, requiring prolonged mechanical ventilation and also need additional blood transfusions. So these possibly add to the risk of ROP, as I'll demonstrate in the study. So we evaluated descriptively the role of septicemia and early neonatal surgeries undergone by these babies during the stay in NICU on the progression of ROP. This was a prospective study done over 3 years from 2018 to 21 in a tertiary care center in South India. And we included 142 babies with any stage of ROP, which were included based on the ICROP classification and subdivided based on ATROP classification. We started screening from day 21, and we were studying 11 risk factors between the babies, and specifically we were noting down the post-conceptional age at which ROP was first detected, started regressing, and completely regressed. And we also saw the post-conceptional age at which these babies underwent these early neonatal surgeries. Statistical analysis was kept, we used the various statistical tests, and the p-value was kept as a cutoff of 0.05. Coming to the results, we saw 16.4% babies developed ROP, most of which were male patients, and out of which 53 babies had type 1, progressive type 1 ROP, including 3 babies with AP ROP. Most of these babies needed peripheral laser ablation, and 2 additionally needed anti-VEGF injections. So this is based on the ET-ROP classification. We saw most of our babies had type 2 ROP. Comparing the risk factors between ROP and no ROP, we saw low gestational age, low birth weight, RDS, apnea, prematurity, prolonged mechanical ventilation, sepsis, anemia, transfusions, ileus of prematurity, and early neonatal surgeries were statistically significant with babies with ROP. Comparing the same risk factors between the subgroups of ROP, we saw definitely a low gestational age, birth weight were typically seen in type 1 ROP. Again, RDS, apnea, prematurity, prolonged mechanical ventilation were associated with type 1 ROP, and these were all statistically significant. PDA, sepsis, anemia, blood transfusion, and surgeries were also typically associated with type 1 ROP. These are the pictures which I'll skip for the now. Coming to the descriptive frequency of sepsis, we saw amongst the babies with type 1 ROP, they had more of gram-negative bacilli, which is Klebsiella pneumoniae, and type 2 had a combination of type gram-positive and gram-negative, that is Acinetobacter and Staph epidermidis. Coming to the frequency of the various surgeries, as we've already demonstrated, type 1 ROP, babies had a greater number of surgeries, early neonatal surgeries, and most of these babies underwent inguinal herniatomy. Coming to the babies with type 2, they also underwent inguinal herniatomy, and mild ROP, also one of them underwent congenital diaphragmatic hernia repair. Now, this is the main thing which I wanted to demonstrate is, we demonstrated the timeline when the baby was diagnosed with ROP, when the babies underwent the surgery, when it started regressing, and it completely regressed. Over here, we can only see for type 1 ROP that there's a positive up curve. So we are seeing that the babies are undergoing surgeries in type 1 ROP between 34 to 35 weeks, and there's a progression seen at around 36 weeks. So we can possibly demonstrate that the role of surgeries is possibly playing a role in the progression in type 1. Coming to our study, to the discussion, so 37.3% of the babies in our study progressed to type 1, which is similar to the study done by Imran et al. This is due to the similar screening criteria, as we also included babies with birth weight less than 2,500 grams and less than 34 weeks. Type 1 ROP definitely had a lower gestational weight and birth weight and needed a long mechanical ventilation support. Sepsis particularly was a strong risk factor, and as I've already shown that Klebsiella pneumoniae was a strong associated factor. And none of the babies with mild ROP had any septicemia associated. Coming to the demonstration of how this is possibly affecting ROP is, these microorganisms are releasing toxins which come out of the leaky retinal vessels, causing a retinal microthrombi, leading to retinal micro non-perfusion. Also, it adds on to the oxidative stress in the retina, which increases the VEGF levels, causing neovascularization. So 24 babies in a study, in total they underwent these neonatal surgeries during their NICU stay, out of which 66.7% progressed to type 1 ROP, 25% developed type 2, and 8.3% developed mild ROP. And we noted that 3 of these babies developing type 1 underwent more than one surgery. We also noted babies had a progression of ROP after surgery in the group with type 1, as I showed it in the graph. So coming to the literature, they say that inguinal hernia in preterm infants below 33 weeks has been estimated around 13%, which we can also see the most common surgery done in the cohort of our babies. And the time of surgery is controversial because they say that the hernia should be operated early in these babies to avoid complications. But again, it's a debate between the pediatric ophthalmologists and the pediatric surgeons over here. So how these surgeries possibly are affecting the eye and ROP is possibly because they're going under general anesthesia, needing a prolonged mechanical ventilation. I'll just come to the conclusion, sir. So the purpose of a study was to monitor these preterm babies undergoing any surgical interventions during their NICU stay and to follow them up more frequently, specifically between the age 34 weeks to 39 weeks, because that's when they're undergoing the surgery, and that is also the time period when the progression of ROP is noted. Thank you.
Thank you, thank you. So
why they were doing hernias in this age group? Can't they wait? I mean,
so that is the thing. A lot of pediatric surgeons, they do say between, there are two schools of thought. Some say that you should do it before, some say you can wait and come for another after the baby is discharged. But in our hospital, they prefer that while the baby is in the NICU, you do it. And a certain people also say that if you prolong it, there's chances of incarceration, testicular incarceration. So they don't want to wait for after later age.
Hernias are not, I think, such a serious matter. I don't know much about hernias. I
Yes, sir,
accept
this is
my
something
ignorance,
which we
but I
observed.
think it should not be such an emergency to my
Was
mind.
general anesthesia responsible for?
Yes, ma'am. Because of general anesthesia, the baby was kept in the NICU on prolonged mechanical ventilation, and most of these babies also needed additional blood transfusions. So these also possibly indirectly added on to the oxidative stress on the baby.
And they are premature children, their immune system, everything is compromised. I think that's also it's a multifactorial thing probably,
Yes,
and
sir. Yes,
it's
sir.
not easy to pinpoint that probably there is one reason for the whole thing.
Yes, so that's why it's a debate between the pediatric surgeons
Yes,
and our
true.
Thank you, thank
and
you.
they always want to do early surgery. Their trend is to do early surgery, so that's the problem, I think. Thank you so much.
Thank you, thank you. So this is the end of the session of this Pediatric 1. The winner will be informed for the semi-finals, which will be held at the 4:20 in the Hall P. So, yeah. Thank you very much.
Thank you all of you. Thank you all of you. Finished on time. On time. Thank you. It was your management.
एक कोई वो कर ले
वहाँ रखा होगा